Hello, everyone. My name is Danielle Cunningham, and I am one of the QA and trainers for ViaQuest Psychiatric and Behavior Solutions. And today I'm the trainer that is going to be leading you through our mental health basics training. So first, we're going to start with objectives. And so they are to gain an understanding of the categories of mental health disorders, identify common mental health diagnosis and associated symptoms, and understand the best practices and common mistakes in engaging with residents. So first, we're going to go ahead and start off with the relevance. And so many residents you have served have mental health disorders. When we interpret a behavior not as defiance or rudeness, but as a sign of anxiety or depression or trauma or any other mental health challenge, we're more likely to respond with empathy, patience, and appropriate support. This will then assist you in providing person-centered care and avoid escalation, especially when supporting residents with mental health needs. This requires empathy, awareness, and a tailored communication strategy. Understanding mental health is highly relevant in today's world, especially for caregivers, educators, support staff, and families. And so it provides a foundational knowledge that helps people understand, recognize, and respond appropriately to mental health challenges in themselves and others. So being aware of mental health symptoms enables you to recognize and respond to them when they appear in the residents you serve. And this awareness is essential for providing timely support, ensuring safety, and promoting overall well-being. Now, many times behaviors are a result of mental health symptoms. And so knowing this can assist with increasing successful interactions. Now, behaviors related to mental health are actions, reactions, or patterns of conduct that influenced by a person's mental or emotional state. These behaviors may reflect underlying mental health conditions and can impact how individuals interact with others and manage their stress and function in daily life. So let's talk about empathy and why empathy is important. Empathy is critically important when working with residents who have mental health disorders. Empathy builds trust and rapport, which in turn helps create a safe and non-judgmental space where residents feel heard, understood, and respected. This foundation of trust encourages open communication and greater cooperation with care plans. Many residents with mental health disorders face social stigma and isolation. When caregivers demonstrate empathy, it helps by validating their experiences and treating them with dignity, helping them feel accepted rather than judged. And so, understanding a resident's emotional state and perspective enables caregivers to communicate more effectively. Empathy also allows staff to tailor their language and approaches based on the resident's needs and sensitivities. So, in moments of distress, residents may become agitated, anxious, or withdrawn. And so, empathetic responses such as calm, compassionate listening can diffuse tension and prevent situations from escalating. Empathy encourages caregivers to see the individual not as a diagnosis. It helps ensure the care is holistic and tailored to the resident's personal history, preferences, and emotional well-being. And so in our next slide, we're going to watch a video where Ms. Brene Brown discusses empathy, and she talks about the differences between empathy and sympathy.
Build a website you love with Wix. For your words,
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay, so just how I have mentioned that empathy plays a critical role when it comes to providing person-centered care to our clients. All right, so let's start with defining what a mental disorder is. And so it is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion, regulation, or behaviors that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. And so, in simple terms, a mental health disorder, according to the DSM-5, is more than just feeling sad or acting out. It is a recognized condition that causes real suffering or difficulty functioning, and it stems from internal problems in how the brain or mind works, not just from outside stress. And so when we talk about mental health diagnosis, this involves disturbances in one or more of the following areas. So mental health diagnoses are severe disturbances in behavior, mood, thoughts, processes, and or interpersonal relationships. The symptoms impact overall functioning across settings and cause impairment in work, family, social life, or other areas. Now, when we talk about behavior, this can look like such as aggression, withdrawal, or impulsivity. When we talk about mood, this can include prolonged sadness, extreme irritability, or rapid mood swings. When we look at thought process, this is such as delusions, confusion, or racing thoughts. And then those interpersonal relationships include social isolation, ongoing conflict, or difficulty forming or maintaining meaningful connections. And so these disturbances typically cause significant impairment in a person's ability to function effectively. And so now we're going to go into what is trauma. Okay, so in the DSM-5, trauma is specifically defined in the context of post-traumatic stress disorder, which is PTSD. It involves exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. A resident can be directly experiencing the traumatic event. They develop trauma by witnessing it, whether that is in person or witnessing the event happening to others. And so learning that the traumatic events occurred to a close family member or a close friend, and in the cases of actual or threatened death, the event must have been violent or accidental, and also experiencing repeated trauma or having extreme exposure to adverse details of the traumatic event. This can look like first responders collecting human remains, and then police officers exposed to the details of child abuse. And so when we look at SAMHSA, according to SAMHSA, which is the Substance Abuse and Mental Health Service Administration, they define trauma as an individual trauma results from an event, series of events, or set of circumstances that is extremely, they're experienced by an individual as physically or emotionally harmful or life-threatening, and that has an adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being, which is a result of anything that disrupts one's sense of safety. And so our first disorder that we are going to discuss today is going to be PTSD, which is post-traumatic stress disorder. And so, PTSD is a mental health condition that may develop after a person is exposed to a traumatic event, such as an actual or threatened death, serious injury, or sexual violence. Now, trauma affects each person differently, but PTSD is more than normal stress reactions. Common symptoms include intrusive symptoms such as flashbacks or intrusive thoughts, nightmares, or the avoidance of that trauma reminder, negative changes in mood, and changes in arousal and reactivity. So we're going to keep reading. We're going to keep learning about the different criteria for these specific conditions and why it is important to talk about mental health, to talk to their mental health professional if they are experiencing any of these symptoms. So, looking at trauma exposure for criterion A, to be diagnosed with PTSD, a resident must meet specific criteria grouped into several categories. And so, the trauma must involve serious threat or life or bodily integrity, or it must evoke a response of intense fear, helplessness, or horror, especially relevant in children. So, directing experiencing the traumatic event, this can look like being in the actual car crash or being physically or sexually assaulted. Witnessing in person the events as it occurred to others. This can look like watching someone else get injured or killed in an accident or any act of violence. Learning that traumatic events occurred to a close family member or close friend. And in cases of actual or threatened death, the event must have been violent or accidental. So like in homicide, car crash, or not death by illness. And then experiencing repeated or extreme exposure to adverse details of the traumatic events. And this can look like, again, first responders, collecting human remains, police officers, or trauma counselors hearing disturbing stories as a part of their job. Now, when we talk about the intrusive symptoms with criterion B of PTSD focuses on the intrusive re-experiencing of those traumatic events. These symptoms are characterized by their involuntary and distressing nature, meaning they are not unconsciously initiated by the individual and cause significant emotional or physical discomfort. These symptoms can manifest in various ways, including intrusive memories, distressing dreams, flashbacks, and intense psychological distress or physiological reactivity when exposed to trauma-related cues. Now, when we look at criterion C, symptoms are the key components of PTSD diagnosis, indicating the individual's attempt to cope with or escape the emotional distress associated with the trauma. Now, these avoidance behaviors can significantly impact daily life, leading to social isolation, occupational difficulties, and a restricted range of emotional experiences, according to the NIH, which is the National Institute of Health. So some examples of avoidance behavior can look like efforts to avoid trauma-related thoughts or feelings. This may involve deliberately pushing away distressing memories or attempting to suppress negative emotions associated with the trauma. Efforts to avoid external reminders of the trauma. This can look like residents may avoid places, people, certain conversations, activities, objects, or situations that are associated with that traumatic event. So, for example, if someone who experienced a car accident may avoid riding or driving in a car altogether. And so the next one is criterion D, which is the negative alterations in cognition and mood. And so according to DSM-5, PTSD refers to negative alterations in cognition and mood that develop or worsen after a traumatic event. This involves experiencing at least two of the following. So the inability to recall key features of the trauma, persistent and exaggerated negative beliefs or expectations about oneself or the world, persistent distorted cognitions about the causes or consequences of the trauma, persistent negative emotions, marked diminished interest in activities, feelings of detachment or estrangement, or the inability to experience positive emotions. Now, there are also criterions E, which are alterations in arousal and reactivity, in which residents will need to have two or more of the following symptoms of those. And so those are the difference in the criteria related to PTSD. Now let's talk about some symptoms of PTSD. Now, some symptoms of PTSD may include flashbacks or nightmares. There could also be symptoms such as avoiding things that are reminders of the event, severe anxiety, and uncontrollable thoughts about the event. Now, symptoms of negative changes in thinking and mood may include negative thoughts about self, other people, or the world, hopelessness about the future, memory problems, including not remembering important aspects of the traumatic events. So they may block out memories or struggle with disassociation. There could be difficulty maintaining close relationships. And so as individuals often have trouble trusting people. Individuals with PTSD may be feeling detached from their family and friends, have a lack of interest in activities they once enjoyed, and difficulty experiencing positive emotions and feeling emotionally numb. So when we talk about PTSD and we talk about this with our clients, first we need to change our way of thinking. So instead of saying what is wrong with you, we may want to say what happened to you. Remember that all behavior has a meaning. All behavior is a form of communication. And so what is your client communicating through their behavior? What are the needs they are trying to get met in that moment? So symptoms of trauma are adaptations and survival skills. The effects of trauma are normal responses to an abnormal experience. And so our goal is to help our residents find healthier ways to cope. So our next disorder we are going to discuss is going to be depressive disorders. So first we're going to start off with the what the DSM-5 defines major depressive, and that is a mental health condition characterized by one or more depressive episodes. These episodes involve a persistent an intense low mood that significantly interferes with daily functioning. Now, depression can also look like everyday blues, sadness, grief, or a short-term depressed mood. And many residents may cope with these feelings without significant impact of their everyday life. But major depressive disorder is a common and serious mental health condition characterized by a persistent feeling of sadness, emptiness, or hopelessness, and a loss of interest or pleasure in most activities. It affects how a person thinks, feels, and behaves, often leading to emotional and physical problems that interfere with daily functioning. Now, a resident must experience 5 or more of the following symptoms during the same 2-week period, and at least one of the symptoms must be either a depressed mood or that loss of interest or pleasure. So some other possible symptoms may include changes in weight or appetite, sleep issues, fatigue or loss of energy, feelings of worthlessness or guilt, trouble concentrating, or having suicidal thoughts or behaviors. Some additional signs and symptoms of depression include feeling hopeless, losing interest in activities, difficulty concentrating, thoughts of death or suicide. One thing to note is that suicide and suicidal ideations is not a disorder. It is a symptom resulting from other causes. So other signs of depression can include problems with eating, sleeping, interacting with others, and no longer enjoying pleasant activities. Physical symptoms can include headaches, fatigue, stomach problems, and unexplained and chronic pain. So depression is defined. It is more than just feeling sad. It is a serious mental health condition marked by that persistent low mood, loss in interest, and other physical and emotional symptoms that disrupt a person's ability to function. And so in our next slide, we're going to watch a video where Julia discusses her life with living with depression.
My name is Julia and I'm 19 years old. In 2017, was diagnosed with major depressive disorder. I almost lost this battle. I didn't think it was going to get better, but it did. I've had anxiety since I was a little kid. I always had this feeling that something terrible was going to happen, and that presented itself in tightness in my chest. I'd get really shaky. I would have a lot of stomach pain. Those were the physical ways that it came out. For the longest time, I didn't know that was my anxiety. I just knew that was something that happened to me. Around middle school, I started to get depressed, and it progressively got worse as I got into high school. Everything just seemed kind of gray. and a lot of worthlessness too. I don't have anything to offer. From the outside, I think I hid it pretty well. I was a straight A student. I hung out with my friends. I babysat all the time. I was involved in my church youth group. I didn't let people see that there was something going on. That was what stayed closed behind my bedroom door. Things started to feel more heavy. I started to self-harm as a way to cope. I started having suicidal ideation. I told my mom, I don't think I can keep myself safe. And I know my parents were shocked when they knew how bad it actually was. It was on a Sunday night. My mom called Children's, their hotline. I was evaluated by a social worker. And I think it was honestly the first time I was completely open about what was happening. And I told my social worker that I didn't necessarily want to die. And I knew that I needed a break from what was happening, from all the things I was feeling. And death seemed like the only option. And I just remember crying to her and being like, I don't know what else to do. Like, I'm stuck. Here I was completely broken. I could barely see the point in staying alive. I felt so ashamed of myself. And these people, they just treated me like a person. I felt validated and I had some hope. And I knew that okay, when I ask for help, help is given and it works. And I knew that this break I was looking for could be found in a hospital room instead of dying. Today, I am in remission from my depression for the first time in who knows how long. I'm getting to know parts of me that aren't just anxious and depressed Julia. I'm clean from self-harm. I'm majoring in social work, and I really want to work in behavioral health with children, specifically in a crisis or inpatient setting. I've started to become really passionate about advocating once I made it to the other side, because I almost didn't make it. You're not at fault for where you are right now. It's okay to be afraid, but I don't want you to give up. Because the thing about depression is it lies. You got to fight to be here because it does get better. And all of these lies will eventually go away. You just have to hold on because it doesn't get to win. It doesn't get to take you. Because you're stronger than that and you're worth more than that. And it's possible.
Alrighty, so that was Julia's story, how she talks about living through depression. Alrighty, so continuing on here, our next category of mental health disorders we're going to discuss is bipolar disorders and related mood disorders. So first, bipolar disorder is a mental health condition characterized by extreme mood swings that include episodes of mania or hypomania and depression. These mood episodes go beyond normal fluctuations and significantly impact a person's energy, activity levels, behavior, and ability to function. So let's talk about some key mood episodes in bipolar disorder. So you have manic episode. And so this is a distinct period of abnormally elevated, impassive, or irritated mood lasting at least 1 week and present most of the day, nearly every day, along with increased goal-directed activity or energy. So at least 3 of the following symptoms for if mood is only irritable. So inflated self-esteem, anxiety, decreased need for sleep, more talkative than usual, and those racing thoughts. Some additional ones is very distractibility, an increase in goal-directed activities or physical restlessness, risky or impulsive behaviors. This can look like going on shopping sprees, having risky sexual interactions, or substance use. Some other ones here, hypomanic episodes, so like mania, but less severe and lasting at least 4 consecutive days. It does not cause marked impairment in functioning or require hospitalization. So talking about major depressive episode, and so a period of at least 2 weeks of persistent low mood or loss of interest in most activities, along with some of these symptoms. So this can look like fatigue, sleep disturbance, a feeling of worthlessness, difficulty concentrating, having some appetite changes, or thoughts of death or suicide. Now, there are different types of bipolar disorder. And so the first one there is bipolar 1 disorder. This is at least one manic episode, may be preceded or followed by hypomanic or depressive episodes. Bipolar 2 disorder is at least one hypomanic episode and at least one major depressive episode, so not full manic episodes there. And then this is cyclothymic or cyclothymia disorder, and this is chronic mood fluctuations involving periods of hypomanic symptoms and depressive symptoms for at least 2 years, but not meeting the full criteria for hypomanic or depressive episodes. So those are different types. And so bipolar is a manic episode lasting at least 1 week where symptoms are present almost all the time. So some symptoms of mania can be increased energy and overactivity, easily distracted, needed less sleep than usual, so feeling feels rested after 3 hours of sleep, elated mood or severe irritability, and rapid thinking and speech. And so bipolar disorders involve periods of both depression, entailing all of the symptoms that we just went over, as well as mania, and will cycle between the two. Many residents experiencing mania aren't able to recognize their symptoms in the moment, and they may enjoy being in a manic state due to the increased energy and feelings of elation. So next, we're going to watch a video here where it's going to be explained what can it be like to experience mania, so a bipolar disorder. Let's take some time to watch this video here.
So mania is what people would know as the happy half of bipolar disorder, I suppose. It's when you experience mania, it can creep up slowly. You can feel it coming, but there's nothing you can do. There's this misconception that being manic is fun. It certainly can feel that way at the time, but it's exhausting. It feels like something is stuck inside you, trying to get out. You just keep moving around, trying to release it, but it only makes it worse. And at first it's just little things you notice, like not needing to sleep, you're feeling restless, you're talking really fast, you're talking a lot. You'll want to go out and be social, be the life of the party, start new things, buy new things, and then get over them just as fast. You're fun, you're creative, you have all these ideas, and you just want to show the world what you can do. And it feels like the best high in the world, and you could do anything. And you kind of wonder why anyone would think that there's something wrong with you. You can embrace mania as a gift, but you can't control it. So you always have to be careful about crossing the line between being this creative genius or some kind of hazard to society. And you'll do anything to avoid crashing into depression. Suddenly, you can't take your foot off the accelerator. So everyone and everything is moving too slow. So you keep going faster. You're too loud, you're too intense, and you scare everyone away from you. Your thoughts are racing and everything seems so far away from you and what you feel inside your mind. And so you might try and ground yourself, take a breath, focus on something slow, something calming. And then once you've found a series of constructive activities to drain your energy into, you start to feel like maybe, you can have some kind of control over this illness.
Alrighty. So our next category of mental health disorders we're going to discuss is anxiety disorders. And so what is an anxiety disorder? And so according to the DSM-5, anxiety disorders are characterized by excessive fear and anxiety along with related behavior disturbances. And so the core concepts of anxiety disorders begin with fear. Fear is an emotional response that residents may have to a real or perceived immediate threat. Anxiety is the anticipation of a future threat. Unlike fear, which is a response to an immediate real danger, anxiety is often associated with worry, tension, or unease about things that might happen. While fear is more associated with the flight or flight responses, anxiety tends to be linked with muscle tension and vigilance in preparation for danger. Now, these responses are excessive or out of proportion to the actual situation, persistent, and can interfere with daily life. And so the difference between fear and anxiety is fear is the reaction to a perceived danger, and anxiety is the worry or distress about the possible future threats or negative outcomes. And so understanding the difference is important when identifying and supporting residents with anxiety disorders, where the level of anxiety is excessive, persistent, and disrupts its daily functioning. And so anxiety disorder is different from normal stress and anxiety. It's normal for residents to experience worries, stress, and etc. In fact, worry and anxiety and stress can be helpful to keep residents safe and at times motivated. Now, with anxiety disorders, the anxiety is more severe, lasts longer, and interferes with work, regular activities, and relationships. So now we're going to talk about some categories of anxiety disorders. And so the first one there is going to be generalized anxiety disorder, GAD. And so this is chronic excessive worry and about various aspects in life. This can be stress from work, health, or family. This has to last for 6 months or more and be accompanied by symptoms such as restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbance. The second category of anxiety disorders is panic disorder. This has to be recurrent, unexpected panic attacks, persistent concern, or behavior changes related to the attacks. Agoraphobia is an intense fear or avoidance of situations where escape may be difficult. So this can look like public transportation, avoiding open spaces, avoiding many crowds. Fear of being in places where it is hard to escape or where they may need help. And then the next one is specific phobia. This is the intense fear or anxiety about specific objects or situations. So maybe like flying on a plane, specific animals, or getting specific injections. Some additional categories is social anxiety disorder, which can also be known as social phobia. This is the fear of social situations where one may be judged, embarrassed, or humiliated. Separation anxiety disorder, previously classified under disorders of childhood, but this is the excessive fear concerning separation from those to whom the individual is attached. And then selective mutism. This is the consistent failure to speak in specific social situations, despite speaking in other settings. So often seen in children there. So those is the different categories of anxiety disorder. And so our next category that we are going to discuss is obsessive compulsive disorder and related disorders. So according to the DSM-5, OCD is no longer classified under anxiety disorders. It now has its own category, which is obsessive compulsive disorder and related disorders. And so this reflects the unique nature of OCD and its related conditions. So according to the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, obsessive compulsive disorder is characterized by the presence of obsessions, compulsions, or both, which are time-consuming and can cause significant distress or impairment in daily functioning. And so the cycle of OCD includes those obsessions, compulsive distress and relief. And so today we're only going to focus on obsessions and compulsions. So looking at those obsessions, which are intrusive thoughts, these are recurrent and persistent thoughts, urges, or images that are unwanted and intrusive and typically cause marked anxiety or distress. So residents will attempt to ignore, suppress, or neutralize them with some other thoughts or actions. Obsessions can look like a fear of contamination or germs, intrusive thoughts about harming others, unwanted taboo thoughts involving sex, religion, or violence. And this is the repetitive behaviors. Repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rigid rules. The behaviors are aimed at reducing anxiety or preventing a feared event, but they are not connected in a realistic way to a feared outcome or clearly excessive. So compulsions can look like repeated hand washing, cleaning or checking, counting, repeating words silently, or organizing things in a particular order, and praying or mentally undoing perceived bad thoughts. And so when we look at schizophrenia spectrum and other psychotic disorders, we're going to watch a video next here that is going to explain the voices with schizophrenia and living with schizophrenia. Sorry about that.
You're so dumb. Don't get up. Don't do anything. Stop what you're doing. Don't do anything. Stay in your bed all day. Keep your head up. You are good. Hi, I'm Michelle Hammer, and I have schizophrenia.
Schizophrenia is a mental illness that changes the way you think, feel, and act. It's broken down into 3 separate categories: positive, negative, and cognitive. Positive symptoms don't mean they're a good thing. It's an add-on to your normal behavior. Things like hallucinations, delusions, and voices.
You know, I had so many ghosts and shadows inside of my mind.
A demon was perching on the end of my bed.
Negative symptoms take away from your behavior.
I showed no emotion, and I was just totally out of it.
Cognitive symptoms make it hard to pay attention and hard to focus.
Their brain is just racing. They can't stop.
The pathology of these illnesses has only become recently understood.
Schizophrenia is different for everyone. My symptoms aren't like everybody else's. My first symptoms of schizophrenia was pretty much just zoning out, thinking I was in a different place. Then it turned into kind of voices in my head that just plagued me over and over again. I thought my mother was trying to hurt me. I didn't know what to do about anything because I thought everyone had it out for me, so I didn't know who to go to for help. Sometimes I kind of hear a voice more coming from the right side of my head saying, like, everyone hates you, stop what you're doing, don't do anything, nothing. Well, it's kind of like the other side of me is kind of arguing back with the voice. Don't worry about anything, chill, just chill, breathe, chill, just chill, you can get through it. And it's kind of just like the thing is, who's gonna win, who's gonna win, who's gonna win? When I take my medicine, the good sign wins. I mean, living in the city and having schizophrenia is interesting just because, I do hear voices as I'm walking down the street. So in my head, I'm thinking of the person talking to me, but then I start talking back to the person. And then maybe I'll snap out of it, look around, and like 5 people are staring at me. But mostly I kind of just get plagued by thoughts that are just so repetitive in my head, and they just go around over and over and over again, when really I just want it to be nice and quiet and silent. All through high school, I had this really crazy paranoid delusion that my mother was trying to kill me. Every time she went to try to get me to a therapist or anything, because she knew something wasn't right, I always thought she was trying to ruin my life. So when I went to college, I thought I was free of her and everything was great. And then all of a sudden, my best friend, my roommate, I started thinking the exact same things about her. So realizing that I had the problem was like the start of the entire thing. And that was the hardest thing to do, I think, realizing there was a problem. At 18, I was told I was bipolar, but I kind of knew that diagnosis was incorrect. So at 22, I spoke to a different doctor and I was more honest with him, and he diagnosed me with schizophrenia, and that was like the best thing that ever happened to me because he got me on the right medication, and I feel as good as I can possibly feel right now.
I finally told a therapist about what was going on with me. I had all these problems, and I finally had a name for them.
Over time, we've realized that mental illness is nothing more than physical illness. Talk to as many people as you can. Don't be ashamed. Don't be judgmental.
I see a psychiatrist every other week, and we just kind of talk about things that are going on. Mostly I just share really silly stories with him, and we just laugh a lot, when really he's measuring just my mood. And that's what I know that he's doing. For my medication, I take 7 daily medications, 6 in the morning and 1 at night. The ones in the morning just get me ready for the day, get me focused, make it so I can get out of bed without having a horrible day. And the one at night just keeps me kind of level, knocks me out, and lets me have a good sleep without completely panicking in the middle of the night.
It can be very lonely having schizophrenia. The paranoia, the fear, the voices, everything that goes along with it.
The compliance with medications is going to ultimately lead to a recovery, and your son or daughter can not only be okay, but they can be great again.
It took a process of almost 10 years to get me on the right medication, so I'm glad that I finally am. People think that just because you're on medicine that the voices will completely stop, but you just can't stop the voices. With medication, it's more positive listening. It's more just zoning out. As long as I'm not thinking of negative, horrible things.
My soul was leaking out of my body. I just saw a human being empty.
I'm good. So you can't turn the voices off. You can just make them to what you prefer to hear.
Be conscious of something that will take your attention from that negative situation into a positive one. And, it takes a lot of discipline, but little by little, it becomes a habit.
1 in 5 New Yorkers has a mental health issue, but people don't talk about it because of all the stigma.
There's still a lot of stigma, but people are starting to understand it a little bit better.
Kind of like a big reason why I started my clothing line was that I was on the subway and I looked down the subway train and there was a homeless schizophrenic guy just talking to himself, and I noticed it was in the same exact mannerisms as I do it. So I kind of thought to myself, what's the difference between me and this guy? And I realized if I didn't have my friends, my family, my doctor, I could so easily be in his position. Part of the reason I started my whole business was to just tell everybody that I have schizophrenia. Showing people you can live a completely normal life, medicated, and be a completely normal person. And my whole thing is, if everyone would just kind of tell people that they have a mental illness, there wouldn't be so much stigma. There really shouldn't be any stigma. That needs to go away. Mental illness is so common. How can there be so much stigma? So I kind of wanted to do something that could raise awareness, give back to the mentally ill homeless community, and just kind of make a difference.
Hi, how are you guys doing? Schizophrenic NYC was all made by me, schizophrenic New Yorker, trying to change the way New York City sees mental health, especially the mentally ill homeless. Donate a portion of the profits to help them out. Yeah.
I just pack up my bag, I wheel it over my shop every Saturday, and I just sell my merch, and I talk to amazing people. Yesterday, I met 2 people that work in a psych ward. We had the greatest conversation about psych wards. They totally bought something for me, and they took my card, and they're like, we love what you're doing. This is so great. Mental health professionals love what I'm doing. They always think it's great. I've gotten negative reactions. Like one lady came up to my booth last year and says, I can't believe you would name a business this. This is offensive, and I'm a mental health advocate. This is offensive, and she took my flyer and ran away. And I was like, can I tell you about it? I'm a mental health advocate too. And she just ran away, and I was like, isn't that stigma? Aren't you judging me before I even tell you about it? Stigma right there.
This shirt's pretty awesome. It's not a delusion. You are incredible.
Some common questions that I get is, what medications are you on? Mostly by people in the mental health field. They want to know. Other common questions are like, how to handle somebody in a crisis. I mean, definitely never tell them that they're wrong. Don't try to take away their feelings. You always have to be sympathetic. I would try to convince them that they should seek professional help. Find a good doctor. Find the meds that work. If you try hard enough and you really want to fix it, you can. Don't take your medication, feel better, and then think you don't need your medication anymore. I took a lot of pride that I had to say, I need medication, and I'm just going to take it.
My advice to someone who's going through it is be honest. If you keep telling people you're fine, they'll believe it.
I believe there is a component beyond medical treatment that it has to be with education and creating positive voices that can influence and override the negative ones. Just because.
Alrighty, so that was Michelle's story with living with schizophrenia. And so now we're going to go into psychotic disorders. And so they are a group of serious mental health conditions characterized by disruptions in a person's thoughts, perceptions, emotions, and behaviors, leading to a loss of contact with reality. Now, these disorders are defined in the DSM-5 based on the presence and duration of core psychotic symptoms such as delusions, hallucinations, disorganized thinking, and abnormal behavior. And so some core features of psychotic disorders are delusions. So these are the false beliefs that are firmly held despite clear evidence to the contrary. So believing one is being followed, has special powers, or is being controlled by outside forces. Hallucinations. This is perceiving things, often voices, that are not actually present. So sensory experiences that occur without an external stimulus. The most common are auditory hallucinations, so hearing voices, but they can also involve any sense, so visual, tactile, or etc. Disorganized thinking and speech. This is thought patterns that are incoherent, illogical, or tangential. It is often reflected in speech that is hard to follow, jumps topics, or uses nonsense words. Disorganized or abnormal motor behavior. And so this includes unpredictable agitation, inappropriate behavior, or that lack of movement or response, so the catatonia. And then negative symptoms. This is primarily in schizophrenia, so that diminished emotional expression, lack of motivation, reduced speech, loss of interest and pleasure, and social withdrawal. And so these are the types of psychotic disorders. So schizophrenia, which is a chronic condition where psychosis is a core feature, with symptoms such as hallucinations, delusions, and disorganized thinking and behavior. Schizoaffective. It is a combination of symptoms of schizophrenia with mood disorder symptoms, so like depression or mania. And in some cases, psychosis must occur even when mood symptoms are not present. Brief psychotic disorder involves a sudden onset of psychotic symptoms that last for less than 1 month. It is often triggered by a stressful event, often triggered by an extreme stress or trauma. And then delusional disorder is characterized by persistent, often elaborate delusions that may involve themes of persecution, grandeur, or jealousy. Functioning is relatively normal, a part of this delusion. And so these are just some of the type of psychotic disorders. And so in our next slides, we are going to talk about personality disorders. And so personality disorders is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is persuasive and inflexible, has an onset in adolescence or early adulthood, and is stable over time and leads to distress or impairment. And so that is according to the DSM-5. So there are types of personality disorders. And so there's cluster A, which is the odd or eccentric, which personality disorders involve unusual or odd thoughts and behaviors. Cluster B is that dramatic, emotional, or erratic. And so personality involves dramatic and emotional thoughts and behaviors that can keep changing. And then cluster C is the anxious and fearful. And so this involves anxious and fearful thoughts and behaviors. And so if you would like a more detailed training on personality disorders, please request that. We do have a separate training on personality disorders. And so our next disorder or category that we're going to discuss is ADHD, attention deficit hyperactivity disorder. And so attention deficit and hyperactivity disorder, ADHD, is a chronic condition that affects millions of children and often persists in adulthood. It includes a combination such as difficulty paying attention, hyperactivity, and impulse behavior. And so symptoms must create significant impairment in functioning and not typical for the developmental level or age. And so ADHD will go into adulthood in about 10 to 60% of childhood cases and is present in approximately 4.5% of adults. And so some symptoms of ADHD. Now, these are typical symptoms that we may think of when we think of ADHD, but we also need to know that that someone may be also experiencing hyperfocus on one specific task. And if that task, they show interest in that. The concept of time is distorted. And so when they do perform tasks, it can be for hours that feels like minutes. So some symptoms of ADHD is difficulty paying attention, frequently daydreaming, difficulty following through on instructions and apparently not listening, frequently has problems organizing tasks or activities, frequently forgetful and loses needed items, frequently fails to finish work, chores, or other tasks. Some additional ones, they can become easily distracted, have frequently fidgets or squirms, difficulty remaining seated and seemingly in constant motion, excessively talkative, frequently interrupts or intrudes on other conversations or games, and frequently has trouble waiting for his or her turn. So these are some typical symptoms that we think about when we think of ADHD. So now let's go into some do's and don'ts when working with residents with mental disorders. And so some things we want to do. We want to practice empathy and patience, use clear, simple communication, respect personal space and boundaries, offer choices and promote anatomy, and stay calm during escalations. Some things we don't want to do is argue or challenge delusions or hallucinations, take behavior personally, overwhelm with questions or tasks, assume your clients are incapable, and use negative labels or language. So just some do's and don'ts when working with your clients with mental disorders. And then some quick tips. Not all residents with the same diagnosis will look, act, or feel the same. And so it is important to understand that residents you are working with and how their mental illness affects them personally. You may need to change the way you are interacting with them to successfully help them through the episode. Listen and observe. Make sure that your residents' treatment plans make sure you know your residents' treatment plans so that you are aware of the interventions that are already suggested for your residents. One of the biggest triggers to our residents is when attention is not going to them. And so it is extremely important that while on shift, you are trying to engage them and spend time with them and keep your personal items for your personal time. Avoid getting into power struggles or getting defensive with residents you are supporting, and don't make judgments in regard to someone struggling with their mental illness. And so just some quick tips of when you are working with your clients and residents. And so that is going to be the end of our training today. I appreciate you for taking this training, and hopefully you have learned more about the categories of mental health disorders. Thank you.